basic need of every thing, and that is on nutrition in the neonate. For this purpose, we managed to get together Dr. Faridi, who was the head of department at UCMS. Then after retirement, he shifted to ERA Medical College and University, and now is the dean there. And during his period, ERA University has done marvelous job in the field of pediatrics. I've been in touch with him all these years, and his expertise is not only in neonatology but in the field of nutrition and infant and young childhood feeding chapter also. So, welcome, sir, for the meeting. He's going to moderate the subject. To take care of as a chairperson, I have a very young chap by the name of Dr. Kamaldeep Arora, who is a professor at Dianand Medical College Hospital in Ludhiana, and he is a neonatologist and very well known again, and very active in the NNF, and is involved in a lot of innovations and a lot of research and in the field of neonatology. And to speak on the subject is Dr. Gaurav Gupta, who is again from Punjab. He did his training in neonatology in Australia and is now providing human services to the neonates in the region of Punjab in near Ludhiana, a small town, but doing an excellent job. So welcome all three of you. And now what I'll do is I'll ask Dr. Kamal to introduce Gaurav, and then Gaurav can go ahead and give the lecture. So,
I think,
Dr. Freedy, you are at
yeah.
liberty to stop and add on things as and when required during the lecture.
Thank you. Thank you. I'll do that. We have actually, I've already discussed with Gaurav, and I'm sure that things will be quite smooth. And let's see.
Okay.
Okay, sir. Dr. Kamal, please go ahead.
Yeah, sir. So I'm very happy to introduce Dr. Gaurav today. He's a very good friend of mine, a very dedicated neonatologist, and you will come to know with this lecture actually how passionate he is about the nutrition in the neonates. He has been trained from Westmead Hospital in Australia, and he did his training there. And finally, he came back to Punjab to serve his own community. Dr. Gaurav, up to you now. And please go ahead with the session.
Thank you. So we'll jump straight into the topic. Am I audible? Is it all okay?
Yeah, perfect.
Okay, that's okay.
I'll start sharing my screen.
Yeah. Yeah, we can see. Just make it slides show. Yeah, perfect.
Okay, thank you for the opportunity. I would, without wasting much of the time, I would straight away jump into the topic. So so how we plan to go about this course is we're going to speak for another 35 minutes, and then we will, I think, keep the forum open for questioning and discussion. Is that okay?
That's how actually we planned, and I'm sure as the lecture progresses, we would definitely be already discussed, and you'll see that how the things go. And I'm thinking that's perfectly okay. Please go ahead.
Okay. So what are the objectives of my presentation today? So first and foremost, I would be discussing what is the importance of this topic. Then we would be discussing difference between term and preterm nutrition. Then we would discuss about what are the conundrums surrounding preterm recommendations. What are recommendations? Then we'll come to nutrition recommendation and preterm neonates with some practice guidelines. We would summarize them and what future research implications this presentation has, or what we can, the direction in which we can direct ourselves in for future research. I would like to conclude by that. So the reason for discussion is nutrition is an important component for both term and preterm babies. So if we look at preterm babies who constitute a major chunk of low birth weight babies, they constitute nearly 15% of total live births. But unfortunately, they lead to 80% of neonatal deaths. This number roughly corresponds to 20.5 million babies a year, which is quite a lot. And surprisingly, 26.5% of these are born in Southern Asia, of which India is an important component. Just by looking at three parameters, that is thermoregulation, prevention of infection, and optimizing nutrition, we can bring down this mortality and morbidity in this particular age group quite significantly. Hence, we are here discussing about nutrition. Our aim is not just to survive, but to thrive and to have good neurodevelopmental outcome, especially in preemies. Our aim is to do no harm. So, a low birth weight infant is at a triple disadvantage as far as nutrition is concerned. Number one disadvantage is it was during the last trimester of pregnancy, that is when the maximum accretion or transfer of intrauterine accretion of nutrients is supposed to occur. Unfortunately, because of preterm birth, that neonate is at a disadvantage that this transfer of nutrition is not happening. Number two, he's since he's born preterm, he or she is sick and has increased energy requirements, which further puts the neonate on a negative energy balance or a negative nutritional status, and inadequate feeding skill and gut immaturity. Because in the postnatal life, it is the gut which is going to be involved in uh, absorption and accretion of nutrition, and immaturity of the gut and immaturity of feeding skills impairs nutrition further in low birth weight infants. So it's not one, it is three disadvantages which a neonate or a low birth weight infant has to cope with. So as far as term neonates are concerned, it depends essentially on what the physical state is, whether it is a sick neonate or a healthy neonate. So a healthy neonate should go directly onto mother's breast, should be commenced on direct breastfeeding right from the word go. Whereas a sick neonate for any condition, may it be for meconium aspiration, may it be for respiratory distress, for any reason, we need to commence enteral feeds as soon as we know the cardiorespiratory status has stabilized, irrespective of what respiratory support we are on. Only contraindication is if there is a surgical contraindication to start enteral feeding in a sick term neonate. So this slide just highlights the same. The first picture on the first left side shows a breast crawl, which needs to be practiced soon after birth. And the second is exclusive breastfeeding. So private and public, both sectors need to be equally involved in promoting exclusive breastfeeding. It is just not single persons, it is a team approach. And I think together we can do it, especially in a resource limited country like India. There's nothing better than express breast milk for a lot of neonatal problems. So no points for guessing. Indian Academy of Pediatrics, Ministry of Health and Family Welfare, Government of India have laid huge importance to exclusive breastfeeding. There is the IMS Act, which needs to be followed in spirit so as to promote exclusive breastfeeding. This subsequently gets followed up by weaning or complementary feeding at 6 months of age. So just having developed the the Infant and Young Child Forum of Indian Academy of Pediatrics, we can know how serious our academies are or our bodies are regarding nutrition in neonates and then in infancy. So when we come to preterm nutrition, it is a conundrum. There is a lot of confusion. It is a maze. As this topic itself, looked like a maze to me, because it's just the humanity, the length of this topic. It becomes little difficult for me to, put my head down and think what do I need to discuss and what I need not. So why do we consider nutrition or preterm nutrition a conundrum or a maze? Because there are so many guidelines on preterm nutrition that one can get confused. But this was a paper which was published in Journal of Parenteral Enteral Nutrition 2024 this year. This is published by New Zealand team headed by Melina, and they have reviewed all these guidelines for which have published on nutrition in preterm infants. So what they started off with, some 7,007 studies from database, and the studies were excluded. They used the Prisma flow diagram, and ultimately they narrowed on to 27 guidelines, which followed the systematic review and meta-analysis flow reporting system, and they applied the grade tool to assess for the adequacy of these guidelines. To our surprise, this number is just 23 on this page. Only 7 of them actually were of high quality. A lot of published guidelines for nutrition in preterm are not according to the grade tool or the agree tool, which is for assessment of guidelines in for any guidelines. So these were 6 domains which they discussed under scope, purpose. Second domain was stakeholders involvement, rigor of development, clarity of presentation, applicability, and editorial independence. They gave high, if it was more than 60% for any 3 domains, especially the third domain, that is rigor of development. And only 7 of 27 could go past the high quality mark. And of these 2, the one by National Institute of Health and Dietetics Department and WHO 2022 guidelines really were a benchmark with overall quality of above 90%. And that is what all the 4 reviewers who were assessing were happy to put these recommendations unchanged without any modification. So what is the problem? So the guidelines lack stakeholders involvement and rigor of development. Hence, there is considerable variation in recommendation, thereby putting certainty of evidence and strength of recommendation at compromise. However, most of the recommendation agreed on type of feeding and fortification, but there was a lot of variation on intake of individual nutrient and monitoring of nutrition adequacy. So with all this confusion, I sat down to put my head around and see what I could come up best with for nutrition and preterm neonates. So as a scientific mind, I was thinking of what to feed, when, how, where, and who. So I have made best attempt to look at biological plausibility, best available evidence, and further applicability. As we all are very vocal for local, we have to apply these recommendations based upon our local viability or feasibility in our unit. So no points for guessing. Express breast milk is number 1. There is no second option. It is preferable to express breast milk or donor human milk, pasteurized donor human milk, and which is superior to formula feeding. Fortification becomes an important concept, especially in very low birth weight infants, less than 1,500 grams, and very premature infants. However, nutrition supplement for low birth weight infants is pretty much limited to vitamin D, iron, and zinc supplementation. So we have just said mother's only milk is the best milk, but what are the issues? The major issues are, as such, mother's only milk is not sufficient to fulfill the need required for a growing preterm or a very low birth weight infant for all the nutrition content, because he needs energy. Or just mentioning he, and I just did not mean to be gender inequivalent. So he or she needs energy or nutrition not only for resting energy intake, for growth, and for to account for whatever gets wasted because of metabolism. So if we look at content which are really less in mother's milk or mother's only milk is protein, calcium, phosphorus, fat soluble vitamins, iron, zinc, and folic acid. So thereby the need for fortification. So these are some of the recommendations which I have taken from SFGAN, the European Society of Pediatric Gastroenterology, Hepatology and Nutrition 2022 paper, which was published in Journal of Pediatric Gastroenterology and Nutrition 2023. So there is a strong recommendation for mother's only milk as the first choice for both term and preterm babies. Fortified donor human milk is conditionally recommended over preterm formula in infants who are less than 32 weeks and 1500 grams. When providing donor human milk, healthcare workers must increase awareness of benefits of mother's only milk over the donor milk. Healthcare workers must support and facilitate mothers to provide higher rate and volume of mother's own milk. So thereby, we have specific pumping stations in all NICUs where we are constantly supporting mothers to increase their production, and there are lactational counselors on floor helping mothers increase their own milk. There is regarding pasteurization of expressed breast milk from CMV positive mothers is there's insufficient data because pasteurization leads to destruction of a lot of bioactive factors. Moving forward, so we have looked at fortification. We are essentially enhancing the nutrient content of mother's milk to meet the demand of a growing preterm. Now, there are two ways to do the same. Either we can do a multi-component or we can add individual multiple components. So the problem with adding individual multiple components is that we are going to increase the chance of infection, and we are going to increase the osmolality by adding individual multiple components, and that is a major risk factor for necrotizing enterocolitis. So rather single component or single content which has multiple components added to it is a better option, with grading of recommendation as A. When do we start it? When we reach an enteral volume of 40 to 100 mils per kilo per day. There is a concept of we don't paint everything with the same brush. Now we have moved away from standardized fortification to adjustable and targeted fortification. Essentially, adjusted fortification means we look at what the status of a neonate is, of a specific growing neonate is. If we find the child is growing is protein deficient, we increase our protein content. If we find that we are doing too much on energy, we cut down on energy. So it is more of adjustable fortification. Whereas in targeted approach, we look at the mother's milk for content of protein, carbohydrate, because it's a very dynamic thing, and we complete, or we fulfill the gap between what is the requirement and what she's producing by adding required fortifier or components. So American Academy of Pediatrics has recommended us to keep our osmolarity less than 400 milliosmoles per liter, and osmolarity which is equivalent to osmolality of less than 450 milliosmoles per kilo. So because that is one big predictor of risk for necrotizing enterocolitis, which is a big problem or can be a probable problem in very preterm neonates. So when do we cease fortification? As soon as we reach 40 weeks of postmenstrual age or 2 kilos, whichever is earlier. So these are some of the fortifiers which are available in Indian market. I'm not promoting any. They're all available, and most of them, they help us achieve our target for individual nutrition component.
Yes, ma'am. Yeah, can we activate the whiteboard here on Zoom? Yeah, sure, you can. So how do we do that? Does the speaker have the rights to share? Yes, ma'am, everyone can share. Okay, that should be enabled actually.
No, everyone cannot share. Only those people with the right.
Sharing also. Right.
I think it is Kamal's phone, because I think he's on another talk.
There is a participant chats, react, share, apps, and 3 dots are there more.
I'll just ask him to mute him.
Just
So please mute. Kamal, please mute yourself. Kamal, please mute yourself.
Please unmute yourself. And ma'am, after my client introduction, to whom will I hand over the session? Yeah, Sindhu ma'am, Dr. Sindhu will be joining. Dr. Sindhu, okay, thank you. So ma'am will introduce her.
Please, Kamal, please mute yourself. Yeah, please, Gaurav, go on, please.
Okay, sir. So this is what they have tried. They have tried fortification with preterm formula. So this was a study which was done by the Ames group and which was published in Journal of American Medical Association in 2021. What they have tried to do is they have tried to fortify mother's own milk with the preterm formula. What is the advantage? It is economically more viable. So they looked at a trial in which they added 0.4 gram per 10 ml of breast milk, and they found it was non-inferior to human milk fortifier. However, there are certain issues. There are two significant drawbacks. First and foremost is pulling up such small amount of formula powder to add to mother's only milk is a little problematic. However, they have come up with an option of providing appropriate sized spoon, which could deliver 1 gram of powder to be added to 25 mils of mother's only milk. And the second major issue was, despite fortification, the final product was less or did not have the adequate amount of calcium, phosphorus, vitamin D, and zinc. So additional fortification with calcium, vitamin D, phosphorus, and zinc was required. So now coming on to individual components. So as far as volume is concerned, we look at a volume of 150 to 180 mils per kilo per day to achieve the desired nutrient intake. For individual preterm infants, the volume may be increased to 200 mils per kilo per day, but it is still a good practice point rather than with concrete evidence. So the desired energy intake should be somewhere between 115 to 140 kilocalories per kilo per day. And an important concept in energy intake for preterms is that it is not just the carbohydrate energy, it is also the non-carbohydrate energy other than the protein which a neonate is getting. So other than proteins, carbohydrates and fat should be there in adequate amount to promote accretion. If there is no fat, then the protein is just going to be used as sugar in a growing preterm. So we need to aim at protein energy ratio of 2.8 to 3.6 grams of protein per 100 kilocal of energy. So grade of recommendation is B. So now looking at proteins, a very preterm neonate needs around 3.5 to 4 grams per kilo per day of protein intake. There is no recommendation for specific amino acids to decrease neonatal morbidities. In a neonate who, regarding routine monitoring of blood urea nitrogen for infants being fed proteins, a blood urea nitrogen concentration of greater than 34 milligram per deciliter in absence of any renal or fluid imbalances, with adequate energy intake points to, indicates us to come down a little bit on proteins. As far as carbohydrates are concerned, they should be 11 to 15 grams per kilo per day. A higher carbohydrate content may be given for short time for catch-up growth. That is, but still is just a good practice point. Fat intake of 4.8 to 8.1 grams per kilo per day. MCT oil or medium chain triglycerides should not constitute more than 40% of total fat. DHA should be somewhere between 30 to 65. Arachidonic acid should be 30 to 100 milligram per kilo per day. Eicosapentaenoic acid should be less than 20 milligram per kilo per day. Sodium, 3 to 8 millimoles. 8 is a little bit on the higher side, which has to, we tend to be on higher side of sodium when we are giving high energy and protein intake, or when there are high sodium losses, especially can be seen in extreme preterms with renal tubular immaturity who would be losing a lot of sodium through their kidneys, may be given in that such a scenario. And one thing which we need to be very sure with sodium is whatever our need is, that has to be distributed over 24 hours just to maintain low osmolality. Again, highlighting how high osmolality can be a problem for us, increasing the risk of NEC. Calcium and phosphorus, as I highlighted earlier, is much less in mother's own milk. We need to fortify mother's own milk with appropriate calcium and phosphorus. So it is just not the absolute amount, but it is also the molar ratio of calcium to phosphorus, which is very important. It should be less than 1:4 for appropriate accretion. So calcium intake of 120 to 200 milligram per kilo per day, and a phosphorus of 70 to 115 milligram per kilo per day. Iron, another important nutrient, 2 to 3 milligrams per kilo per day, may be used as a higher dose in infants receiving erythropoietin, but this would not be very much applicable in our Indian scenario. Preterm infants after 6 months of age should be on iron-rich complementary feeds, which includes green leafy vegetables or jaggery, or in Hindi we can say ganne ka juice. So anything which has iron-rich complementary feeding. And delayed cord clamping is something which has become universal even for preterm babies. It gives more iron stores uh, and decreases the need for transfusion in preemie babies, not only in neonatal period but also later on in their growing phase in infancy. Zinc is required for in the dose of 2 to 3 milligram per kilo per day. Zinc level measurements need to be done when there is concerns on poor growth with low alkaline phosphatase levels, or if there are excessive GI losses. So these are doses for some of fat-soluble vitamins. Vitamin A is in the dose of 1.3 to 3.3 international units per kilo per day. Vitamin D takes a lot of precedence, 400 to 700 international units per kilo per day, but nothing more than 1,000 international units per day. Vitamin E, 2.2 to 11 milligram per kilo per day. Vitamin K is 4.4 to 28 microgram per kilo per day. All these individual component nutrition requirement can be fulfilled if we are giving mother's only milk fortified with any of the fortifiers which I have mentioned earlier, and the volume is around 150 mils per kilo per day. We can essentially fulfill all these individual component requirements. So essentially, we have discussed about the phase during growth in neonatal intensive care unit. Once we reach 2 kilos or 40 weeks of postmenstrual age, that is when most of these tubings and things are over. That is when the child is ready to go home. We need to supplement vitamin D3 and iron drops, 1,000 international units per day for 2 years of age, and iron of 2 milligram per kilo per day. Now, this is another table from AIMS protocol recent edition, where infants who are low birth weight, we need to supplement with vitamin D, roughly around 400 units, international units per day till 2 years of age, and iron again of 2 milligram per kilo per day, starting from 4 weeks of age till 2 years of age. So we've discussed upon what to feed. Now we are coming on to when to feed. So that again goes back to the same question of what depends upon the physical state of the child and how preterm a child is. Now, if we have a sick, low birth weight or a very low birth weight infant, we need to start it as soon as possible once the child is hemodynamically stable, irrespective of the respiratory support. There are a lot of studies and there are a lot of units, just like Sushma ma'am's unit from Lady Harding. They start off with full enteral feedings from day one of life itself. So even for a sick neonate who is on CPAP support, early enteral nutrition is an answer, or is the feeding of choice. Healthy low birth weight infant further needs to be commenced on enteral feeding as soon as possible. However, the method would be based on gestational age and neurological maturity, which I will be coming on to later. Extreme preterm infants who are less than 28 weeks, we need to be aggressive with our parenteral nutrition. We need to put in a central venous catheter, give our parenteral nutrition with minimal enteral nutrition to line the gut with some milk, mature the gut lining, get good gut hormones moving, and then we can advance our enteral feeds based on tolerance. Flow abnormalities, those children who are born with umbilical artery flow abnormalities, especially the ones with absent or reversal of diastolic flow, they may be kept nil per oral for 24 hours. And once we know things are fine, lactates are down, hemodynamically the child is stable, we may commence enteral feedings. Good to start off with mother's only milk. So this is rate of advancement. Slower advancement at 15 to 24 mils has no advantage over faster increments. So we need to go higher at a faster pace. There is no difference in incidence of necrotizing enterocolitis. This is from Cochrane database 2021. Now, this chart is looking at, as we move from 28 weeks to 34 weeks, we move from extreme preterm to very preterm to moderate preterm and then to the late preemies. So as we move up, there is better sucking effort, then there is better suck swallow breathing coordination, and there is better gut motility. So essentially, this slide helps us in deciding for hemodynamically stable babies what mode or how to feed these children. For especially for extreme preterms, you need to start on orogastric feeds, which would be putting a tube down, and starting feeds. The same may apply for very preterms. Whereas for 32 to 34 weeks, we may consider starting them off with pala-day feeds or katori feeding, and more than 34 weeks, under observation, direct breastfeeding can be commenced, especially under the nose of a lactational counselor or an experienced nurse. So now, recommendations regarding feed intolerance, routine monitoring of gastric residue is not advisable or is not recommended. However, gastric residual assessment should be done when there is evidence of feed intolerance or necrotizing enterocolitis. Feeding pattern, as I have already mentioned, oral feeding should be guided by competence and stability of preterm, may be started from 32 weeks post-menstrual age. Bolus feeding is physiological. Continuous feeding is not physiological, so bolus feeding is preferable. However, very, very rarely continuous feeding is done when there's risks on reflux disease, but your nursing care has to be very good. Establishment of non-nutritive sucking is good. It helps, it helps in reducing time required to reach full enteral feeds. So next component is growth monitoring. So now we've looked at the initial part where we were very aggressive with our total parenteral nutrition if the child was not hemodynamically stable or if if things were not good for enteral feeding. Then we commenced our minimal enteral nutrition, and then once we went on to full enteral feeds or to substantial feeds, we started to fortify. We got the child to grow. Now we need to monitor how the child is growing. So just by administering or just by deciding upon the micronutrients, macronutrients, type of feeding, fortification, our job doesn't end. We need to be very careful in monitoring how our growth is. That is equally an important part of nutrition surveillance. So weight gains need to be done daily. Initially, there's going to be a loss. We all know that. But then once they start growing, they grow at 15 to 20 grams per kilo per day. So I just wanted to highlight this concept of grams per kilo per day. We always mention this weight gain in terms of grams per kilo per day. Now, just giving you an example, suppose a growing preterm who was a VLBW or an ELBW started to gain weight. Now, in a matter of week, if he or she has put on around 150 grams, suppose from, or say 200 grams, from 1400 to 1600 grams. So the numerator would be 200 grams. Denominator would be mean of 1.4 and 1.6, which would be 1.5. And that would further be divided by 7. So that would give us around 15 to 20 grams per kilo per day. So once we are post 36 weeks post-menstrual age, we look at an absolute weight gain of 20 to 35 grams per day. So lengthwise, we need to do it weekly, around 0.7 to 1 centimeter per week. Need to use an infantometer and head circumference of 0.7 to 1 centimeter per week. Now, this particular graph I've taken from AIMS protocol in neonatology. So there's an important concept which I need to show. So most of us, there are two types of growth monitoring charts or anthropometry charts which we can use in a neonatal intensive care unit. There are ones which go at the rate at what accretion would have been in intrauterine period, and there are some growth charts which look at growth trajectories or weight gain based upon postnatal growth chart. As a rule, just familiarize yourself with one particular growth chart, be confident in using that, and just use that rigorously. So this is a Fenton's chart. So the bold line in center is the 50th centile or the mean. The one which is one above and one below is one standard deviation above and below the mean, and the second line or the thinner dotted line is 2 standard deviations above and below. So essentially, a 28 weeks child who is born at 1 kilo is going to have a postnatal weight loss. He's going to lose that some extra, volume which is there, and and he does not have the comfort of intrauterine accretion at a rate which was, our postnatal growth can be no match, especially in initial phase, to what would have happened in intrauterine environment. So there is going to be a weight loss, and the child is going to follow a curve which is going to be 0. The Z score is going to be minus 0.8 standard deviations below the mean. So we need not follow them up on this mean 50th centile score, rather on minus 0.8 standard deviations, and they would tend to follow that growth curve. It's very hard to get them to follow their intrauterine growth curve. So I would like, but also for terms, mother's milk is the best milk. Early initiation of direct breastfeeding when feasible, or mother's only milk is important. Every neonatal intensive care unit should have a standard feeding protocol to avoid nutrition deficit, and growth monitoring is an important aspect of nutrition management. So what does this leave for future research and guidelines formulation? Our guidelines need to use the AGRI and the AGRI 2 and the GRADE tool. They need to be used more rigorously. All domains need to be used more rigorously. That would help us in consistency of recommendation and higher level of evidence. And we need to have more research or more recommendations specific to specific gestational ages. Thank you.
Thank you so much, dear Gaurav. Excellent. You could do the justice. I'm sure all the participants listening to this will agree with me that the speaker made the justice with the topic. Very vast, very difficult topic, and almost brought everything into few things I like to emphasize here. And
Yes,
one of them is that we always talk about the breast milk to be given, but in practice, this is happening. We have seen that this actually takes the back seat. So my very earnest appeal to all the pediatrician neonatologists here would be to please invest little more time on the nutrition part, especially to managing the mother's milk in the NICU. It's extremely difficult, and even today I had a meeting with the colleagues here, my AP and my associate professor and the nursing staff, that still we are finding 1 or 2 odd mothers are clandestinely feeding the formula milk in spite of all the efforts being done, because they get stimuli from so many quarters, right from our OBG colleagues, their other friends outside, the practitioner in the outside. So it becomes very difficult to actually manage the mother's breast milk in the NICU. So that's a very, very important part. Remember that I'll give you a little insight into what is actually happening. You see, the newborn baby, the capacity of the trypsin and other enzymes in the stomach to digest protein is 30% less than the infant and the adult. It's very important point to remember, because see, the breast milk has antibodies, and antibodies is a protein. So if these antibodies get digested in the stomach, then what is the fun of having the antibodies in the breast milk? So the nature has provided that the activity of the enzymes digesting the protein is 25 to 30% less. That is in the normal newborn. In preterm babies, it still be less. So the baby will not be able to actually metabolize protein of any other source except the mother's milk, because that protein structure is entirely different from the animal milk source protein. So therefore, it becomes very important that we provide mother's milk. The second thing is about the epithelial growth factor. Even in a term baby born a 40-weeker, 3.2 kg, the gut is not fully mature. It still needs the modeling and maturity. What to talk about the preterm baby? So therefore, it's very important. Physiologically, that we should give the mother's milk. So that's one point, they emphasize on that. The second point is about the requirement. Has already talked about the energy requirement, talked about the osmolarity part. But remember that the newborn baby requirement is about 150 to 130 kilocalories per day, per kg per day, rather than the infant having 100 calories per day. And the sick baby will require it more. The BMR actually is consuming about 60%. In us is about 50%. So the more is actually be required for this baby. And initial few days, as very rightly said, about 24 waiting for 24 hours or 48 hours, this baby will definitely lose weight. And the way very excellently presented, we should not aim to actually get the intrauterine growth curve, rather than minus 0.8 is perfectly okay. Trajectory is maintained, and that the trajectory is maintained, I'm sure that we have achieved. So that point also to be kept in mind. A baby who is transported baby already suffering from cold stress or hypothermia will require more energy. So some of these points are extremely important when managing. Simultaneously, you manage looking after the hemodynamics, you're looking after the respiratory support part, but equally important, and therefore I agree with Dr. Sushma, you referred to her, that we may not wait for 24 hours. In fact, with all the other things we are doing, one can also, even in a hemodynamic unstable child, we have seen 10 to 15 ml per kg divided into 8 feeds or so, or 10 feeds is not going to harm the baby. And as we use more and more, we become more confident. And the world is actually moving from the more invasive to less invasive thing. My point is, I'd like to ask Gaurav, for our participants here, the baby born with meconium liquor, what is your recommendation about the feeding? Term baby, naturally we have generally meconium liquor in a term baby. Do you advocate gastric lavage before starting the feeding?
So you're asking me?
Yeah, Gaurav, to you.
Sir, if there is no evidence of, there is as such no indication for doing a routine lavage for babies born through meconium stained amniotic fluid. Yes, if there is some evidence, of gastritis, meconium can cause gastritis, can cause irritation, So if there is some evidence, consider doing it, but as a routine, there is no point doing a gastric lavage in babies born through meconium
Thank you very much. In fact, large studies include our own study on 1,500 babies divided into two groups, randomized trials. We found that the gastric lavage actually neither helps in maintaining the breastfeeding, nor it's causing secondary mass. So there's no need to do it, and we can go on. But there's still some of the units I found in UP that they routinely do gastric lavage. That's not needed actually. So that's one point which I said, okay, not only we're talking about the preterm babies, but also we are talking about the preterm babies. What about, we would like to say a few words on the IUGR baby in terms of the feeding requirement? Gaurav, would like to say a few words on that? IUGR babies?
Kamal, would you like to?
Yes, sir. So what is happening with the IUGR? These are a special class. So we have a group which is the term SGA or the term IUGR, and another class which is a preterm IUGR. So that's a double jeopardy. So we are having issues with the prematurity and as well as a IUGR. So what is happening? These guidelines what have been projected here are basically the preterm guidelines. We add on to vitamin A, vitamin D, iron, and everything. So for SGA, we don't have any specific guidelines currently available with us, but we should make these guidelines, and these are underway. When the AIMS protocols we made, these are underway. Currently, we are following the guidelines, a mixed part of it. So if a baby is like a term, but SGA less than 1500 grams, a VLBW baby, we follow guidelines like we follow for a preterm babies. So we give them vitamin D, we give them iron and calcium till 6 months. Iron is continued for longer time rather than this one. But because now a special group is coming up with the absent diastolic flow and the reversal of flow. Absent diastolic flow. If these are not an SGA babies and they have crossed the gestation of 34 to 35 weeks, then we start feeds as a normal baby. We don't wait for any weight or for like 24 hours, 48 hours, keeping them NPO. We don't do that part. And we are doing a study here in our ICU here, in our NICU here in Ludhiana. We are finding that if a baby of an absent diastolic flow or a reversal of flow has to have a NEC, which is like a NEC, I would say, not an actual NEC, but an ischemic NEC, then they will develop an abdominal dissection within first 24 hours. Otherwise, you can feed them as a normal babies. Our AIMS protocol still says that we have to wait for 48 hours. The ADAPT trial said that we have to wait for 5 days. Now we are going again with that part, wait for 2 days. So currently, if there is an SGA component, we wait for 48 hours, we give, and then we increase flow. This is the protocol.
Yes, Kamal, I agree with you. This is a very separate class and not much literature available on this. So that actually needs to look into
Yes,
it, as we have to little more search, and we can, in India, can have some multi-sector studies on that. But I'd like to say here that
we
the
need that.
mother who has given birth to an IUGR baby, it has been seen that the amount of lactose in the breast milk is lower compared to milk produced by a baby born to a term baby, AGA baby. So this area remains to be actually gone into. We generally are treating them generally as treating a preterm baby. I won't go into the further discussion of vitamin D, although recommending that I have excessively reviewed this topic and seen that even in America, who were the first 2009 brought out the recommendation of 400 international unit to all babies since birth to up to 1 year, the compliance rate has been found to be only 37% up to 1 year. So that's the issue. Another thing is that the vitamin D is an OTC product, and therefore, and the uniformity of the doses is not there. So many times, if you replace by one product to another one, per ml, the amount of the vitamin D varies. And there are case reports from Europe as well as from America of toxicity. And therefore, the recommendation of American Endocrine Society is that if you're giving vitamin D for a longer duration, then you must at least check 3 months or 6 months the urinary creatine and calcium ratio. Again, one has to be very careful about it. Therefore, another school of thought is coming up. Then instead of supplementing the baby, you can supplement mother, because mother is also vitamin D deficient. An excellent number of result Cochrane reviews are available. We are also in UCMS had about 4-5 designed studies have shown that vitamin D supplemented to the mother during lactation or even during antenatal period from 30 week onward takes care of the deficiency of vitamin D. So I won't go into the topic is not related to that, but yes, there is a need to look after both iron, zinc, and vitamin D. Whatever way you do it, but the recommendation, we are waiting for the new recommendation to come where either you supplement baby or supplement mother. More are now in favor of supplementing the mother. So that's another one. So now still we have got 5-7 minutes. So any participants want to ask any question, it's open to discussion, any question, or they can write in the chat box. And there's one question I'm seeing by Dr. Shinoy. The parental nutrition is same infant admitted with urinary tract infection. ICU protocol, any update? So yes, because the topic is up to nutrition in neonates. The question is actually a little, outside the scope of today's talk. But anyway, Gaurav would like to say anything on that, or Kamal?
So they're talking about nutrition in infant admitted with UTI.
Same. Severe
Along with
acute
malnutrition.
Yeah.
Sir, essentially we need to, parental nutrition in whatever we can supplement, we would supplement with in an age appropriate manner, whether it be the proteins, carbohydrates, fats, or whatever, we need to do it. Simultaneously, we'll treat the urinary tract infection. And whenever we can start enteral nutrition, we would aim to start enteral nutrition and build upon that.
Actually, we also like to say a few words upon the different terms he used for nutrition. Like, for example, dietary reference intakes. So this means that nutrition needs are objectively defined using term dietary reference intake, estimated average EAR. EAR actually is the nutrition required by about 50% of the population in a given community. And RDA is 20% higher than what is the EAR. So for this RDA and this has not been established individually for the preterm babies or term babies. Only we are talking about, as said by Gaurav, that you go initially by so many gram per kg per day, and then once this becomes, then you go by per day. So these terms are also very important to remember, that the RDA or this, again, the RDA is 20% more than what the average for the population. So in the same situation, I think that the no special for, because it's a UTI, some special diet to be given. The age appropriate nutrition, both in terms of the calories, in terms of macronutrients. But one thing I've learned in our adult ICU, we discussed about the nutrition part. We have got two DM critical care people here. We've got excellent facilities in ERA Medical College for ICU patients. When they calculate calories, they actually write in the nutrition box, or everything is online. They write protein excluding calories. That means the calories provided by protein is not included in the overall calculation of the port. So that's a game point. So what do you think, Gaurav? Is that also true for preterm babies? Could you lay your hands on some literature? Like you said, 3.5 to 4 gram per kg per day,
Yes,
for a per day baby. So when you calculate the
so
total calories, are you taking into account the calories provided by the protein?
So if we are essentially supplying, there's a concept of non-protein calories, sir.
Yes, non-protein calories for sick patients.
Yeah, so the carbohydrate should constitute 40 to 50% of non-protein calories for proteins to be used as a building block. If we do not do that, then the proteins are just acting as a source of sugar, which would be giving, 1 gram would be giving somewhere around 4 kilocalories. So we need to put in our lipids in to provide enough amount of calories so that the proteins can be used for accretion or can do their job of doing a building block.
So here I also like to add that the studies have shown now that the lipid profile of infants on exclusive breastfeeding and on formula is qualitatively different. In fact, the baby require initially more cholesterol because our brain actually is lipoprotein. So they need more protein. All enzymes actually are cholesterol based. So in fact, they need more cholesterol. And so the lipid profile of exclusive breastfeed infants has a higher cholesterol level compared to the formula fed baby. Any comment on that? You could lay your hands on about, because we are talking about protein-free calories where we are providing, so that you have to add more fat into it. And there's a fat. Everybody is worried about more fat is going to have more cardiovascular diseases. The cholesterol levels in exclusive breastfed infants are higher than the formula baby, but they are protected later on from cardiovascular diseases and metabolic syndrome. The reason is that the body is actually tuned to, the metabolic system of the body is tuned to take care of higher amount of fat in the beginning. So that's again a very exciting area of the research. So would you like to, Kamal, like to end on that? Or we have also published, on our 2 papers are there on this aspect. The formula fed babies or mixed fed babies and actually breastfed babies have a different lipid profile, higher cholesterol in them.
So right, actually you said the basic. This is what we also do the same thing. I would just like to add something different from this, sir. Now it is almost like 8:58 and we are left with two more minutes. How many of you are still waiting for your dinner to start with, your nutrition to start with? So similarly, the baby is waiting for their nutrition. And remember that somebody must have left from this group because they're waiting for the dinner, they're waiting for this khana aa gaya Zomato se kahin se bhi aaya. So the similarly, it's basically a medical emergency. So nutrition is a medical emergency. If you don't provide nutrition, your baby is going to land up with a sepsis. The parenteral nutrition, the enteral nutrition is the key to reduce a sepsis. It's a key for the growth of the baby, and it's a key the baby goes discharged well at home. So if you want to actually avoid the complication in the NICU, don't get the baby in the NICU. If you get the baby in the NICU by chance, मदर से लेके आयो बेबी को, तो उसको न्यूट्रिशन दे दो, नहीं तो मदर भी गुस्सा करेगी, बेबी भी गुस्सा करेगा. And if you start the nutrition, please start early and progress that feed early. Don't wait 10 ml per kg daily weight increase. You can increase with the 30 ml per kg. It's now proven by the Cochrane. So if you increase it early, your baby goes home early, the sepsis is less, the interventions are less. This is basically, I always write as a writing to my staff also and my residents. So please, रात को भी डरो मत, फीड स्टार्ट कर दो. अदरवाइज जैसे कि अभी तो रात है, सुबह फीड करेंगे, रात को कुछ हो गया तो. सो डोंट वेट फॉर दैट नाइट में ज्यादा भूख लगती है बच्चों को. दे आर मोर एक्टिव इन द नाइट. So start, it's a medical emergency, start early, start aggressively, reach full feed, send the baby home. You will have a quiet sleep yourself and you can have your nutrition well at home. So that is what my message to all of you is, and slightly different from what actually specifically we were discussing. And another thing is nutrition is our goal is not the weight gain. What Dr. Gaurav has told you, it's not to thrive. It's basically to live a neurologically intact life. If your lipids are known for this brain growth, they carry the neurons, and the lipids carry the neurons to their subcortical. Neurons reach the cortex. They reach from the general matrix to the cortex. That is basically the lipids are required. So if you don't give lipids, if you don't give proper nutrition, these are babies going to be handicapped. And then you will say that premature babies are bound to have behavioral issues. They're bound to have ADHDs. They're bound to have autism and all those things. So this is basically nutrition has started all this issue. Please be careful whenever you think about the nutrition. Think about your nutrition. अगर आपको भूख लगी, बच्चे को भूख लगी. I hope I'm clear in this, giving the message.
Thank you very much. Excellent. Excellent. Thank you so much.
Okay. Thank you very much, all three of you. Excellent discussion, Dr. Faridi and Dr. Gaurav and Dr. Kamal. A beautiful, simple lecture and giving very crucial basic points. Thank you all, everybody, and good night to all of you.
Thank you, sir.
Right, sir.
Thank you, sir.
Very, very happy Dussehra to all of you. Thank you.
Thank you, sir. Thank you.
Okay, thank you, sir.
Thank you.